Welcome everyone, and thank you to those joining us live and to those listening in afterwards. I'd also like to warmly welcome our guest today, who I will shortly introduce. My name is Chris John. I am the FIP lead for the Evidence and Impact Digital Event Programme 2022. I'm also the FIP lead for Data and Intelligence and Secretary of the FIP Data and Intelligence Commission. I'm a UK registered pharmacist. FIP's vision is a world where everyone benefits from access to safe, effective, and quality and affordable medicines and health technologies. Our mission is to support global health by enabling the advancement of pharmaceutical practice, sciences, and education. We're pleased to be delivering this event, which is episode number 2 of a programme of 3 events of our Evidence and Impact series. This special webinar programme events is being delivered between May and October this year. With the facts, data, and science at our disposal, we can provide evidence of impact that advances pharmacy and pharmaceutical science. Across healthcare systems, people are using data more efficiently and effectively, and this has become apparent during the COVID-19 pandemic. And they're doing this more than ever before in a myriad of different ways and essential applications. Artificial intelligence, algorithms, and data-driven technologies are other exciting areas that are improving patient outcomes. So this program is composed of 3 episodes that will focus on developing pharmacy intelligence to provide evidence and impact. In our previous event, we looked at evidence and impact, where we are now and where next for data intelligence for advancing pharmacy worldwide. But today, we're really going to focus on building data and intelligence capabilities to provide evidence of impact for the profession. The next digital events will run on a regional basis, and they're being held in October, and they will be about creating development goal indicators, bridging data and outcomes. Just have some of the usual announcements for this webinar. To reassure you will all receive certificates after the webinar. We will be sending those via email. The webinar is being recorded and live streamed via YouTube. The recording will be available on our website if you visit www.events.fip.org. You may ask questions using the Q&A box provided if you have any specific questions for our speakers. Hopefully we'll have time at the end to visit those in a panel discussion. You are welcome to provide feedback on any of our webinars to webinars@fip.org. And also you can join FIP as a member by visiting the address at the bottom of that slide. So FIP, the development goals we have launched by FIP in September 2020 are a key resource for transforming the pharmacy profession over the next decade, globally, regionally, and nationally. They align with FIP's mission to support global health by enabling the advancement of pharmaceutical practice, sciences, and education, and are set to transform pharmacy in alignment with the wider global imperatives underpinning the United Nations Sustainable Development Goals. We have a global pharmaceutical observatory, which will be monitoring progress towards these development goals, and it does that by tracking them using data that we collect through our various surveys and other data collection processes. Today's event links very closely to Development Goal 12, Impact and Outcomes. You will see each of the development goals breaks down into workforce, practice, and science elements. So today's event will look at the evidence of the impact across workforce, particularly pharmaceutical services as well. It also strongly links to FIP Development Goal 12, Pharmacy Intelligence, and particularly across workforce and practice, having a national strategy and corresponding actions to collect and share workforce data and workforce planning activities, also having national strategies to collect, share, and utilize intelligence on service provision, development, delivery, and needs to inform evidence-based pharmaceutical services development, policymaking, and funding decisions. Of course, all of this is dependent on having the capabilities to collect data, to analyze data, to use data. So you've got to have strong health information systems. So today's program, we will be focusing on strengthening health information systems. We're delighted to have our speaker, Anne Chu from WHO. We've got Dr. Astrid Schock talking about, from the practice perspective, about generating evidence of impact. And we have Sajja Al-Nahar from Jordan talking about from the workforce perspective. Pharmacy needs to build sustained data and analytics capabilities, as I've said, and these need to support evidence-based decision-making and advocacy interventions that inform policy development. Improving capacity in data and intelligence across FIP and its member organizations is essential to advance pharmacy worldwide. So this event explores challenges and opportunities that maximize the use of data to generate evidence of impact across safe and effective use of medicines, pharmacy practice, and pharmacy workforce, as well as looking how to strengthen health information systems, which is the first learning objective, and you'll see the other learning objectives up on the screen there. The aim of this event is to describe approaches for delivering the required data and intelligence to generate evidence of impact for the profession and current and future policy. So looking at the enablers and barriers that will support this through practical approaches. So without further ado, I'm delighted to welcome from the World Health Organization, Anne Chu. And Anne Chu is a technical officer working in the area of health service data in the Department of Data and Analytics in the Division of Data Analytic and Delivery for Impacts at WHO HQ. She is currently overseeing and leading the work on health information system strengthening, assisting countries to enable effective health data systems. And in her current position, she contributes to the work of standardization of the routine health data collection, analysis and use, which is a collaborative effort across various programs in WHO in guiding countries to strengthen the quality and use of health data. And that's particularly for monitoring of health targets and managing health services. These standards set the foundation for the development of digital packages that have been adopted by partners through what is called the DHIS2 platform, which is a platform that collates data. And this initiative now has been implemented in more than 60 countries and was instrumental in the response to the COVID-19 pandemic. So Dr. Anne is a medical doctor with a master's in public health, and she has extensive experience working with the United Nations agencies to support countries applying result-based monitoring and evaluation to strengthening programs and health service systems. So I'm delighted to welcome Anne Chu, and the floor is yours. Welcome.
Thank you very much, Chris, and good morning, good afternoon, and good evening, colleagues from all over the world. And it's my privilege to be invited to talk on this related to my current area of work. And thank you, IFP, for inviting us as WHO to join this conference and seminar. Next, please. So, my task today, or the talk today, is mainly very much of setting the theme for the webinar today, and it's about how, as WHO, we work together with the member states, but also with multiple partners to support countries to strengthen the health data or health information systems. And with the COVID pandemic in the last 2 years, there's a lot of lesson learned, but also a lot of revelations of the data gap, but also the need for data and the use of that at countries and at subnational levels. And this is going to be the focus in the future as part of our work to support the strengthening of the health service and the response to any of the emergencies, but also strengthening the routine and essential service in the countries. So just to start with, I'll briefly talk about the need to have a flexible, adaptable, but yet owned by the countries for the data system. Nowadays, people move more towards have the health information system for health rather than just the health information system, because the technology has advanced a lot, but also we see that there is more than just the one system that's serving the purpose of identifying and collecting data for the use of strengthening the health services and managing it. So we just a quick look at here, and you can see that there are various systems of data collection and use that used by the health sector, from the data that collected by multiple programs in the health service, the logistics, the laboratories, as well as going into the infrastructure, the civil registration and vital statistics, lots of different information on the surveys, the routines, all of that are put together and serving the daily use for the health facility manager, but also for the planners and the public health sectors and private sector as well. So this is something that cover a lot of areas, and it's very much driven by the use of it at the facility and at the subnational level. Next, please. So in the scope of the talk today, I'll just mainly talk about what we do in WHO, especially in the department that I'm currently working with to support countries. We look at it through three dimensions. Number one is to setting up standard methods and tools so that country would be easy to adapt, and also to scale up for the implementations of the data collections, of the surveys, and all different way of collecting data at countries to serve the purpose of the management of the service and monitoring of the national health related goals, but also for the monitoring of the universal health coverage and the SDGs. Secondly, is through the strengthening of the collaboration in data governance across countries and partners, so that we would have a united front to support the country to strengthen the data collection and the data system to use for the health management purposes. And then as a part of the UN system, we also look into how we work together and support country to monitor the progress that each of the country make for reaching the sustainable development goals and the universal health coverage. Next, please. One of the asks that Chris and I discussed when we started looking into what would be the way to develop this session is to see the latest publications on WHO is the global assessment tool to see the capacity in the country for data collection and data system for health. Of that, it covers quite a good, a comprehensive brands of different intervention that is needed for country to strengthen the data system for health. And come with that is a multiple document that I will mention in the next slides. But the score for health data technical package is it's called, and you can find them available in the WHO website that I refer to at the bottom of the slide, is covering the key five areas. The first three is looking at the data collection, common data collection methods. Number one is on population-based survey, special surveys, and also the disease-specific or disease surveillance survey system. Secondly is on the count of who is born and who died in daily or in the period of time. So we look at the birth and death and cause of deaths, and that is very much linked and cause and play a quite significant part of the civil registration and vital statistics. And this is, you look at, if you look at the person's life, you know, you have the birth and the death and anything that link in between, that happened between this cycle of life, that is linked to the vital statistics and the vital statistic. And then the third one is on the optimizing for health service data. This is the most common, and this is the backbone of any data system for health in the countries. They collect all the data that related to the health services, from who coming to the facility, if they have the enough the bed, how many beds they have, what kind of health service providers they have, to what side of service they are doing, how many people that are receiving the service, who are the key clients for the service facilities, are they private or are they public, do they have enough commodities, medicines, what are the laboratory systems, how they work together, to, all the preventive medicine that, reaching out to the community. We talk about the immunization, the health informations and education, to own the preventive measures of nutrition and activity that is carried out by the health facility in the community, or by the community health workers. So the C and the S and the O are talking about all these different data collections that provide the information and the data related to the health services. And then come to the R, which is the review and also the capacity of the country, how they use the data that they collect. Apart from the usual practices reporting, do they really look at the data and how these data are used for the day-to-day management of the health facility and the health service, how they use it for the planning purpose, but also how they use this for the policy making, the strategies and the country development goals. And finally, you look at the foundation of the data system. We look at the governance, we look at the infrastructure, we look at the capacity of the country to own the data, to the capacity of the human resource, how they manage the data systems, and also the legislation, the coordinations and collaboration with all different partners to make sure that the machines of data collecting and use in the country is smoothly run and managed. Next, please. This is a very brief. You can find all of this in the WHO website. You just look for the score in WHO and you can find this. This is a set of documents. So we have the essential intervention that refer to the 5 key interventions of that would build the data system for health in the countries. We also have a list of all different tools and standards that has been developed and published by not just WHO, but by all different partners in the past 10 years. This is kind of an exhaustive list for countries to look at and see if they identify the needs for strengthening certain area, if they can look into this and see how they can adapt it to the use of the systems. And then in 2019, we did a global assessment of the global data system for health in the countries, of which 133 countries have participated, and the results are also available on the website. I do not want to take too much of time to look into that, but please go and check on that. These 133 countries that has participated, we look all those different systems and different interventions and identify. The objective is to identify the data gaps and work with the government to build it as a part of the priority for the next 5 or 10 year strategies, and then using the tool and the standard. And at the same time, we also develop more tools and standards for the country to adapt and use that. The report of the assessment, but also the recommendations are available on the website as well. Next. This is so this is a link to the report, and you can see that there is very big coverage. For each of the data collection component, as well as for the capacity for the use of the data and the enabling factors are reflected in this. And also there's interactive website with maps and all different analytics also available on the website. Next, please. Just very brief, you will see that, throughout the 133 countries that participated, it's not much a big, the average is about 50–60% of the country that reaches to a acceptable or average capacity. But one of the key points that I would like to highlight here is that number one is for the surveys, most of the countries are still very much dependent on donor and support. And this is referring a lot to the low and middle income countries. The vital statistics are another weak area, and the COVID-19 have also revealed that, and we just published the global estimate for excess mortality due to COVID, and you will see that there is a big gap in country data on mortality. We don't know how many people died. We don't know what caused the deaths. Therefore, the work on establishing and identifying the cause of death and also the number of deaths are very, very important. And some part of the world, this is a very, very big gap. And And you can also find that in the reports. Another gap is the capacity from the routine and the facility data to identify the gaps in the equity. We don't know who are actually the one who don't have good access to the facility or to the health service, and what caused that. So this is also an area that we identified as one of the areas that need a further investment, but also support to the country as well. Next, please. So what we do, the aim is to make sure that every country should have a data system for health that serve, as I mentioned earlier. Number one is to make sure that all the population have equal access to it. Number two is that the facility would have a data to support the planning, to support the management of the health services, and also to respond and prepare for any emergencies and outbreak that can happen. And I think this is going to be the future, especially after the COVID, and now we have the monkeypox. So we never know what is going to happen next, and the best way is to make sure that there is a system in place, that is a data that we can use, and then can investigate further if needed. So what we do is that we try to set up as much as possible the standard ways to collect the data, and then also guide them to analyze it, so that all the country would be able to adapt it and use as much as possible. So all the tools on the surveys, on the vital statistics, as well as on the facility data, that we are still trying to find a way to improve and make it simpler. And the use of technology is ever so important, as it makes it much easier and faster and more reliable data for the country to use. We also look at all different packages and resource, and work together with partners to find a way that align all of the supports and put country at the center of it, so that the country know that they own the data system. They can get support to use the data, but also to share the data where it's needed, because data should be an open product, and it should be a global goods. Next, please. So I'm just very quickly go through this key area of the standard and tool that we have. Number one is the World Health Survey Plus. This is something that we build it as a modular set of all different survey tools and questionnaires and standard, and help country to institutionalize it, so that we don't have to depend on all the time on donor and build the capacity, so that they would have a constant way of monitoring the population status of health, and also some of the key services. We are working with multiple number of partners and trying to link this with different data sources from the facility, but also link with the administrative data systems, so that the country would be able to monitor it on a regular basis. And this is for the population-based outcome and outputs. Next. Next, please. The second is the civil registration and vital statistic. As I mentioned, this is something that has becoming a common, a kind of common denominators that not just health, but many of other sectors in the society and in the country also need to look into that. From the WHO point of view, we would like to do a few things. Number one is to work with country and member states and work with partners to strengthen the coordination, because the data on birth and on death and anything in between serve a very important purpose. We use it to know, one is, what are the population? Who are they? Do we know all of them? The subpopulations. Number two is that, there's lots of people who are mobile and refugees. How we know them? We would be able to register them, or for those who are not registered, how we're going to identify them. And then the work on the legal status, the work on identify the denominator, the work on educations, and then on vaccination. So all of that this is as a backbone at the center of that. So from WHO, we would like to see that there is a stronger coordination across multiple partners and sectors that use this at both international level, but also at the country level, and bring the ownership of the country to a level that is the data should be shared and used in an efforts across all different sectors. On the health sector, we wanted to look at number one is there is a registration and use of birth, but most importantly also the use of death, because that is where we understand the burden of diseases. We understand more of what mean the cause of death, and then from there, so a lot of policy can be made and put together. The latest one that we published in the in the global statistic report is the non-communicable disease, which is the third cause of death among all among all the countries. So this is something that we can put the efforts and the investment together and find a way to prevent that. Next, please. There is a work plan that has been published, and you can find that you can find these documents in the WHO website. The idea is that we should have a team working at HQ, but also with the regional offices and in the country, and work across different partners and different sectors to support this work. Next. And then for the mortality alone, we also have what we call the Mortality Database. And this is the work, WHO has been the only organization, and that's our unique role, is to collect mortality data and cause of death data. So we have 70 years of data that reported by most of the member states. Whoever can, they would give us the number of mortality and what the main cause of that. And the analysis of this is very, very crucial to support, all the health sector policy, but also for us as WHO as well as the health agency. Next, please. So this is the vision. I will just leave it here. I don't need to read it, but this is one of the key area that we are trying to address. Is there are cause of death, but there's also death that occur in the community that need to be collected. And again, if you have a time, please look at the excess mortality due to COVID report in WHO. It raised a lot of alarm, but also the need to see why we need to look into this and support the country to collect and report on mortality. Next, please. The next one is just very quick one, is on the survey at the facility to help the facility to manage. Number one is the human resource, the infrastructure, what is going on in the facility, the commodity, the drug use, and also part of it is quality of care as well. And it go beyond just the general for the health system, but also go for program specific, what is needed for what program or what disease. And from there, it helps country to monitor, but also to plan for mainly for the management of the health facility. Next, please. And then this is the part that, as Chris mentioned, this is where I spend most of my day on, which is how to work with country to strengthen the routine data collections. So it is more than just what is provided by the health facility, but also what is needed by the facility. And we wanted to know the type of service, the kind of service people are looking for, but also to see who are the population we serve, what we need to give them, and how to reach them. So we also reach beyond the service. We look at the workforce, the essential commodity and drugs, the stocks, the laboratories, as well as its infrastructure. All of that go into these systems. So we collect administrative data, which is the registry of patients, but also we collected the outcome and output of the service as well as the input of the service. So this is a very complex, but also it is a bread and butter for any health facility data systems. Next, please. And we're trying to do it by, number one, instead of just collecting, we're trying to turn the table around, say the data use is the most important. People will not use the data or will not collect the right data if they don't know what they need the data for. So instead of saying this is what the agency A or agency B or the minister needs. That is very important, but also important is to say, what do they use as a service provider, as a facility manager, especially at the primary health care level, where in low and middle income countries, where resources are always limited, how are we going to make the best out of that? And that is what we're trying to focus. So we look at that and then build in the foundational, the governance, the ownership, the capacity, and then build it in with the standard and data and tool that we do, and then trying to promote for the integration, interoperability of the system, so that we don't have to go and run around, collect different data, but it should be all in the same platform where people should have access to and use it for their own purpose. Next, please. And this is it's the key part that we've done, and now we've reached to about 18 different programs where the data is used multiple times by different programs, and we're trying to set up a list of all different data points that can be collected at the facility by different programs, but also link that with the logistics, links that with the lab, and make the standard analysis. And using the ICD-11 as one of the classes, the standard classification for supporting the assessment and the analysis. But the whole idea is that the data that collected at the facility, there should not be duplication, and that should be reused across all different programs, but also all different levels of the health systems. So this is also available on the website, and you can contact me if you wanted to have more information on this particular piece of work. Next, please. So this is the final part. It's how we're going to implement this. We have the strategies that to support the country, and come with that is the guidance on the framework of how country should start. We have the country readiness assessments. We also have the different way and tools and the standard platform. The idea is that there should be the use of the data should be the center of it, and put the country ownership and country capacity at the center. All the partners should work together and to bring all of this for the country use of that. And then there will be a mechanism, and WHO in my department, we also do that, is to have the global health data platform where country can share the data, which the standardization of the data collection would help the sharing of the data easily, and we can support them on how the best to use that. So I will leave it here as the final notes, and I'm sorry for running a bit over time. I will leave some of the contacts in the website on the chats later. Thank you.
Thank you so much, Anh Chu, for that excellent presentation and showing us all the huge amount of work that World Health Organization is doing across the globe, supporting countries across the globe with their building of capacity for their health information systems and helping them understand the need for data and standard ways to collect data, and all the tools as well that you showed that are supportive of that approach. Thank you so much. Any questions for Anh Chu, please do put them in the Q&A box. And I'm now delighted to welcome our second speaker, Dr. Astrid Schock, who is joining us as talking about the practice element of today's event. Astrid has a Master of Pharmacy and a PhD in Pharmaceutical Chemistry, and has worked in research and development on new oncological treatments in the USA. After working for 8 years as a community pharmacist in Switzerland, she took up a position of Department Head for Science, Education and Quality in Pharma Suisse. She was appointed Fellow of the Swiss Academy of Pharmaceutical Sciences for her achievements for the federal accreditation of the postgraduate titles in community and hospital pharmacy, and the creation and implementation of vaccinations by pharmacists. So Astrid is CEO of QualiCare, a Swiss non-profit association, and this is a multi-stakeholder platform which aims to increase the quality of care for patients with non-communicable diseases in primary care by interprofessionally elaborating national best practices and piloting the implementation, and that being in the primary care setting. Currently, the main topics are multimorbidity, vaccinations for people with non-communicable diseases, as well as treatment of diabetic foot syndromes. Astrid also works for the Swiss Society of Endocrinology and Diabetology, where she coordinates the Society's Commission for Postgraduate and Continuous Education, and is involved in the creation of a postgraduate certificate for the treatment of obesity in adults, as well as coordinating several working groups such as disease management, diabetes, or diabetic foot. And finally, she is one of the 3 FIP global leads for Development Goal 8, FIP Development Goal 8, which is working with others. So I'm delighted to welcome Astrid, and the floor is yours.
Morning, good afternoon, and good evening, colleagues. Thank you for giving me the opportunity to present our experiences from the practice projects. These practice projects, which we are doing, like Chris already said, are concern not only the pharmacies, but also all other healthcare facilities, predominantly in the ambulatory sector. The hospital environment is somewhat different. It might be a bit easier to collect data there than in the primary care setting, and also to implement projects, but this is our goal for the primary care. So to start off, I would like to just give you the contents. What I'm going to talk about is, like, first, why is the data important? And then I would like to mention some of our projects and our experiences with these projects. And from there, the opportunities and challenges, as well as I'm going to propose some possible solutions. And then our final slide will be a take-home messages. Next slide, please. So why is data important in the practice, but also for the practice? So data provides facts, and facts is knowledge, and knowledge gives you power. And data can show impact, but can also show no impact of services which are provided. It's very important to always look at qualitative and quantitative data, not only quantitative data, which very often is prioritized in science, but it is very important also the qualitative data to start to get the scope. So all projects, they generate data, but very often the data is not documented. Politicians and authorities, they need reliable data. This Dr. Anchu also mentioned that it's very important for policy to have the data. And from our experience, it's more important for the politicians and authorities to have the data which is generated in their own country than if it's just from literature. In Switzerland, we do not have any national registers. We do not have any compulsory data collection in healthcare. We have Sentinella surveys. We do have some, but it's all at the voluntary status, and neither the patient nor the healthcare provider is required to accept the collection of their data. We have in Switzerland a cancer registry. We have a law to collect the data regarding cancer in this registry, but the cancer patient still has to sign a paper that he agrees that his data is put into that registry. Same with diabetic feet is also one of our projects. When we were looking at the amputation rates, we can look it up in the Federal Office of Statistics, but there it only says that amputation rates are due to or toe amputation rates. And from there, we infer that it's due to diabetic foot or other polyneuropathies. A new diabetes register is also installed now recently, but it's not a law, and it's in a collaboration of several hospitals, but not at a national level. As I said before, for hospitals, it's easier to collect data than in the ambulatory sector. So just to give you an overview of what kind of projects we are performing, Quality Care is a Swiss national interprofessional nonprofit association. Quality Care is quality in chronic care, so our main focus is in chronic disease, patients with chronic diseases. We invest in the generation and implementation of national best practice recommendations for primary care. We elaborate what existing, we look at existing guidelines internationally or also national guidelines which already exist, and we try to adapt them to the Swiss environment. We pilot projects to see if these best practice recommendations are feasible and are you can multiply them in the primary care setting, because very often you have strategies which are very nice and they show the gaps and they show measures to overcome these gaps, but they're not feasible to be transported and to be implemented long-term in the healthcare setting. So this is what we do. We have project examples. Our biggest project is the optimal care of multimorbid patients in primary care. It's this OptiQ. We are working on it. It's a 4-year project. And we did shorter projects, smaller projects on vaccination. And we are about to start one on acute diabetic foot syndrome. We already elaborated the best practice recommendations, but now we have to transport it into the practice. And we also did one or several projects on the good diabetes management in GP offices. I will talk about some of these projects and our experiences and what you can learn from doing these projects. Next slide, please. So the example of OptiQ multimorbidity, that's our 4-year project, is we elaborated a patient care passport. We did that in a very broad working group. And this patient care passport is on paper. It is always in the hands of the patient. And it is, since we do not have an electronic patient pass like some other countries already have, in Switzerland we do not have this. We've been working on this for a long time, the government, but it's always there's always some issues with the data protection, and so it's really stalling. So for us, we said, like, we will make this patient care passport, which would be like a blueprint for a future electronic version. But now it should be taken by the patients to each healthcare worker or healthcare provider which they visit, also a social worker, so not only in the healthcare environment, or a psychologist. And this is the patient. We also did it in the patient version, in the paper version, due to several reasons, because nowadays the age of the patient who has several chronic diseases is usually higher than maybe 55. Of course, there are some which are younger, but they prefer paper versions, and they're not all of them are IT literate or are at ease with IT tools. And what we heard from our patients in the working group is also they don't want the 5th or 10th healthcare app on their phone, where they have to input their data and repeat the data. It's the same like when they go to several healthcare providers and they have to repeat their health history 5 times. These are things which are a negative point for the patients, which increase their burden of disease, and a paper version of this passport would now, for the patients of today, would now be more adaptable. So, and of course, the third reason we want to, the second reason is also the funding and the time. We do not have the funds from the project providers, from the project management, and we also do not have the time because to implement a digital tool always takes much longer. We have additional tools for the healthcare professionals. We elaborated a patient assessment based on 4 validated questionnaires. We have an e-medication plan, which is digital, provided on a national basis. And we have a medication check, which ideally should be done in the pharmacy. And the e-medication plan also in Switzerland, just as an information, not the GP offices can also sell medicines and dispense medicines. So in some areas, in some cantons in Switzerland, there is no collaboration between pharmacies and GP primary or medical doctors. And this is also another obstacle in the interprofessional collaboration. The project is implemented during 12 months in primary care facilities, meaning GP offices and pharmacies. And we have a pre and post implementation questionnaires to evaluate the impact. And according to the evaluation, and we will generate recommendations for IT tools and remuneration models. So in order to be able to make these recommendations, of course, we need to have the data and the feedback, the written feedback and the facts from the project. Next slide, please. So the current project status is we are trying to recruit GP offices and pharmacies, which is very slow. We are not the only project on the market in healthcare. There are a lot of projects running simultaneously and in parallel, and all of these project managements, they have the same problem. All the studies, they always have the problem with the recruitment. Recruitment is very slow, and it really requires intensive and repeated personal contacts. And there are motivated healthcare workers, especially after COVID. Before we said like, yeah, it's due to COVID, people are not willing to participate. But now we see there's also a certain fatigue, and they're not really too motivated to start something new. But there are some, and we really have to find them. And when you start with some motivated, it's like a snowball effect. They will motivate their peers. And it's also, one problem is like they seem to be less willing to invest in the future advancements, especially the elderly ones. I think the young pharmacists, young GPs, if they know they have another 50 years to work, they are more willing to invest in their profession, obviously. And many, especially in primary care, they don't really see that data is necessary to obtain a remuneration for new services or for new healthcare workers, which provide new services, such as pharmacists or also medical practice assistants, which today are not remunerated. It's just the GP who is remunerated. So one positive side is that all healthcare professionals are convinced that the project is very important and necessary, but they'd rather have somebody else do the project because they don't have time. And what we see is that many don't see is that the patient gains, and they are not considered. A lot of them, they want to have a digital patient care passport, but they don't ask their patient if they are at ease with the digital passport. They just say, like, for me, if I have it digitally, I can input the data easier. The healthcare, and also it's that the patients are, the older patients, they don't feel at ease with the digital. Next slide, please. But on the good side is the opportunities for projects and for data generation is the implementation projects, they generate data. This is very important, and you need to have this data. Data shows the service provided by the different healthcare workers on the market, and they show the time spent for providing services, which is very important, especially like if you are thinking of remuneration. The data, they can show the impact. Medical impact, probably less unless the project runs for 10 years at least. So it's more the impact of organization, of efficiency. These are the impacts which we can show also with the data. The data, they can show an increase of quality of care or a decrease, obviously, and they can show the efficiency. And data can also be used to promote and advance pharmacy services. This is very important if you want to show an impact of the pharmacy practice. And data can provide the proof for remuneration of services. In Switzerland, what the federal government of public health, the Federal Department of Public Health is doing on a regular basis. They are looking at the services provided by medical doctors, and they reevaluate the prices and the tariffs, which after a certain time of years, maybe the services are more efficient and they cost less. So next slide, please. So another project is the Vaccination Projects, which we performed. These were surveys. One was a survey on the cantonal governments. We have 26 different cantons, and in Switzerland, the healthcare law is on a cantonal level, and the federal strategy, healthcare strategy, has to be implemented by the cantons. But each canton can decide how to implement something. So especially like in the prevention, there we have an influenza, we have a national strategy on influenza prevention and a national strategy of vaccination. And each canton implements it differently. So we asked all the cantons what are their activities in the prevention of influenza. We also picked out 5 different cantons where we asked the patients. We wrote to 25,000 patients, and we got about not quite 10,000 answers. And the results from this survey gave us the answers that the cantonal activities do not really show much impact on the vaccination status. What is really important is that the healthcare professionals advise or recommend the vaccination. Besides, of course, their patient's disease status, if they're older, if they are more diseased, they are more open to vaccination. But an important factor is the healthcare professionals. And then we did another survey, where we looked at the healthcare professionals. We looked at the primary healthcare professionals. In the ambulatory sector, and this was we wrote to GPs, GP offices, and pharmacies and nurses, and we could see how that it was a very quick survey. It took 5 minutes for them to answer so many, and we got over 1,000 answers. And it was interesting that if the healthcare workers were vaccinated themselves, they also recommended it more to their patients. And from this, Next, please. We could say that data is necessary to generate this knowledge. Since Switzerland does not have a registry, we don't know how many people are actually vaccinated. We can assume, and we only have small projects which show the impact. But data is necessary to generate this knowledge, and the knowledge should also be considered in future vaccination policies and strategies, meaning that in a vaccination policy, we should also especially address the healthcare professionals and not only the general public. Next slide, please. So this is now the good diabetes management in primary care. It was a project where pharmacies were not involved. I was not working for our association yet, but this was we have a national diabetes score from the Swiss Society of Endocrinology and Diabetology, and they have 8 criteria, quality criteria, and Quality Care tested it in one GP practice, and then in a second project we did 5 GP practices, and now we did with 9 GP practices, and we included 730 diabetes patients. So the questions were this discussion of diabetes disease management, lifestyle consultations, laboratory parameter were documented, and the prevention of secondary complications. The GP offices had to input it. Some had an Excel file. I mean, it's very complicated. We do not have it electronically. This was a main issue for the GP offices, of course, that they cannot input, they cannot use their practice, their patient history software. So what we also had, we always had documented statistically in this last project was the medication status, the medication which they used, influenza, insulin, oral diabetes, anti-diabetics, statins, and antihypertensives, and the influenza vaccination status. And as a result, we could show that the gaps there are big gaps in the secondary prevention, meaning sending the patient to the eye doctor, but especially looking at the feet, controlling the sensitivity of the foot, and also the influenza vaccination status was down by 37%, which for me, advocating for vaccination is not really acceptable for NCD patients. I mean, the WHO recommendation is at least 75% of vaccination rate. Next, please. But what I wanted to show from this example is that again, data generates knowledge. These results, they give rise to the opportunities for showing the competencies of other healthcare workers, and the interprofessional collaboration will be more and more necessary because we have a lack of healthcare workers, and it's going to increase with the increase of age, of the aging societies, and the increase of diseases, which the aging society is going to have. And just a recently published study showed that there was no difference in care, in quality care for diabetes patients when it was performed. The diabetes discussions were performed by medical practice assistants, which were specially trained for chronic care management, or if they were cared for by the GP. So this is something which really can show, and where also pharmacists could show a role. When I first looked at this, it was for me, it was, when I saw this diabetes score, I said, like, pharmacists can take some of the roles and support the GPs and specialists in caring for chronic patients. Next slide, please. So what are the challenges? A very important challenge is the collection of the personal data. It poses ethical issues. You cannot just collect personal data with whatever you like without asking, without also making an ethics demand. If you are not sure, I mean, personal data can be collected for in certain reasons, in certain projects. If it's a quality project, at least this is how it is in Switzerland. And if the data is anonymous, meaning you can have it with, you can have the gender and you have the age and maybe also the region, but that's it. You're not allowed to use any other, any more personal data. You can ask what the patient, the disease, obviously, but this is also anonymous. What is very important is, of course, that you have sufficient funding for the pilot projects, which also can pose a big challenge. It depends on the topic. If you look at the national strategy, if your national strategies, if you see gaps in the national strategies, you can really adapt your projects to the gaps, to fill the gaps and to implement the measures which are in the strategy. And another challenge, of course, is the recruitment of participants for pilot projects. And professionals of today, they need to invest for the professionals of tomorrow. And answers are like the lack of personnel, and I already mentioned all this. Next slide, please. So what are the possible solutions for these challenges is to secure the funding before starting any project, and really know that, or keep in mind that the recruitment requires much time and personal contact. The communication is key. Use all possible challenges and really do not give up communicating, because if you said it 5 times, the 6th time, some people will say, oh yeah, I've never heard of this. So it's very important to stick to your communication. Show prospective participants their personal gain, and if possible, use peers to convince participants. And obviously calculate sufficient onboarding time. Find synergies with concurring or parallel running projects, and for the evaluation, for the data collection, just the less effort for the participants, the better the chance that they participate. Next slide, please. I'm also running a bit late, I'm really sorry. Take-home messages is the data collection is necessary and important to advance pharmacy practice, generate data by performing pilot projects, invest time in recruitment of motivated healthcare providers, work with other professionals, this is very important, and evidence generated in your country is always more powerful to advance your profession in your country than evidence from literature. And evidence always needs to be documented. That's how you can show your impact. Consider the challenges and find solutions. Sometimes you just need to think out of the box. Next. And transform data into intelligence to demonstrate the impact of pharmacy practice. FIP's GPO is doing exactly this, so just help advance the GPO. Next slide. Thank you very much for your attention, and sorry for running late.
Thank you so much, Astrid, for that fantastic presentation and showing us how you have built data and intelligence capabilities to provide evidence of impact, not only for our profession, but actually for other professions as well. And it shows you that higher income countries like Switzerland don't necessarily have all the health information systems in place like the national registries. So you can always get started on projects, data collect, and get as far as you can, I think would be what I've learned from you. You don't need to wait for technology or national infrastructure always to prove the impact of the profession. So thank you so much. And we will now move on to our final speaker. And I'm delighted to welcome Dr. Sajja Al-Nahar, who is Assistant Professor at Pharmacy Practice Division, Faculty of Pharmacy at Yarmouk University in Jordan. So in 2019, Sajja was appointed as Technical Coordinator of the FIP JPA project of pharmacy workforce development in Jordan. And Dr. Al-Nahar completed her BSc degree in pharmacy from Jordan University in 2009. In 2012, she got an MSc degree in health service management from the Royal College of Surgeons in Ireland and Yarmouk University. And in 2014, Sajja started a PhD in social and administrative pharmacy, which she completed in 2018. In addition to her academic record, Dr. Al-Nahar has a practical experience as a chemotherapy pharmacist and also as an industrial pharmacist working in research, development, medical affairs, and quality control and compliance. So Sajja's research interests are related to pharmacy education and workforce development, in addition to medicines management. And she'll be talking from the workforce perspective in this particular event on building data and intelligence capabilities to provide evidence of impact for the profession. So welcome, Sajja. The floor is yours.
Oh, thank you. Thanks a lot. Good afternoon, everyone. And first, I would like to thank the FIP and Dr. Christopher John for offering me this opportunity to participate in this webinar. Today, I'm going to discuss the challenges and opportunity for the illustrating impact of pharmacy workforce. Next slide, please. So we will discuss what is the impact, what is impact assessment, why to assess the impact of any intervention, what to assess, what about the impact of pharmacists and pharmacy workforce, how to assess the impact, and what is missing and needed. First, next slide, please. So first, we need to discuss the or define two important concepts, impact and intervention. Impact is a positive or a negative, direct or indirect, intended or unintended change produced by an intervention. By definition, impact is not always wanted or desired. In some cases, it can be negative or even harmful. So, interventions might be medicines, procedures, operations, education program, social care programs, health promotion campaigns. For example, any pharmaceutical dosage forms, any medicine review services, or new medicine services, etc. Okay, next slide, please. So what does it mean to assess the impact? Impact assessment means any procedures, methods, or tools by which an intervention is judged as to its potential effect on health of a population and distribution of effects within the population. It assesses to what extent the outcome experienced by affected individuals were caused by the intervention in question. What can be attributed to other factors such as other interventions, socioeconomic trends, and political and environmental conditions. By definition, impact assessment needs to be based on scientific and methodological approaches. Any used tool or instrument to assess the impact needs to be reliable and valid. These tools should be able to assess the impact on a different level, at the individual level, organization level, and societal level. Moreover, tools should be designed in a way that can relate the observed impact to its causative activity or intervention, i.e., any tool should be able to help or should help in root cause assessment. Finally, impact assessment should take into consideration social and policy-related factors. Therefore, any use assessment tool needs to be context-specific and context-sensitive. Accordingly, it's not advisable to borrow assessment tools from other systems without making necessary adjustments and modifications. Okay, next slide, please. So why we need, no, the previous one, please. So why it's important and why do we need to assess the impact? First, we need to understand the impact of the introduced intervention, again, at three different levels mainly, individual level, patient level, organizational level, and societal level. Second, identify who was affected and in what circumstances. Understand what groups were affected and how and why. Identifying influencing factors such as enablers and barriers. Finally, helping inform future decisions about improvement and the future rollout. Therefore, we need to generate evidence and gather data. This will help us making evidence-based recommendations for future practices. Next slide, please. Now, assessing the impact triggers and discussing the impact trigger a vital question. What is the difference between output, outcomes, and impact? These terms are often used interchangeably, and some scholars and researchers got confused in using them. Output, the products, capital goods, and services which result from a development intervention. For example, carrying out a medicine review exercise to standard. Outcomes, the likely or achieved short-term or medium-term effect on an intervention's output. For example, improving patient adherence to treatment regimen, reducing the number of side effects, or reducing the number of drug-drug interactions. Impact, positive or negative, primary and secondary long-term effects produced by a development intervention, directly or indirectly, intended or unintended. For example, in this case, improving the quality of life. They overlap, but the right tool and well-trained and qualified assessor can tell the difference. It is important to know which is which, as the impact has longest duration and the deepest effect. Next slide, please. Okay, so we mentioned before that we have to assess the impact at 3 different levels: organizational, individual, and societal. So when we are talking about organizational, we are talking about the overall quality of delivered services. The economic impact, and we need to make sure that any intervention is cost effective. Thirdly, the operation efficiency, to assure that we have a proper allocation of resources. Second level is the individual level. So we are looking at a humanistic impact. Basically, we are talking about quality, patient satisfaction, and overall experience. Societal, how the overall productivity is affected by this intervention, and looking at the public health and well-being. Now, the big question is, what about pharmaceutical services and pharmacy workforce? Next slide, please. Knowing that pharmacists are the experts in medicine in terms of understanding medicine and medicine's pharmacological characteristics, dosing regimen, possible interactions, and adverse drug reaction. In addition, pharmacists, especially community pharmacists, are frequently reported to be the most accessible healthcare professionals, whether in developing or developed countries. Therefore, what is delivered by pharmacists will definitely have an impact. However, it is challenging to assess the impact of pharmaceutical services and pharmacy workforce. Why is that? First, the inability to isolate pharmacist interventions from other healthcare interventions. Usually, pharmacists operate and function within a team of healthcare professionals. It is even more challenging in community pharmacy settings. We cannot isolate pharmacist intervention from other healthcare interventions. Time need to actualize and realize the impact. Note that the impact usually needs long time to be assessed and observed. Thirdly, there is no comprehensive, reliable, pragmatic, and validated tools to assess pharmaceutical services. Limited documentation of pharmacist-led interventions and activities. And lastly, most of the assessment initiatives are limited to clinical and economic impact. So whenever we are checking the literature, you will find studies assessing the impact in terms of the direct cost of medicines or the clinical outcomes. Now, next slide, please. Okay, how to assess the impact? Data. We need data. We need to use more data. So pharmacists should be encouraged to collect data, document what they are doing in terms of activities, document the outcomes, output, and the impact. We need to use assessment tools. These tools need to be specifically designed for pharmaceutical services. We can rely on other tools developed by the WHO, the CLIO tool, which is the Clinical, Economic, and Organizational tool. And we need to have a tool that is able to address the unique aspects of pharmacy workforce and pharmaceutical services. Thirdly, we need to encourage and train pharmacists to document their activities. Lastly, we need to engage with stakeholders, seeking their feedback, whether they are patients, other healthcare providers, policymakers, and policy planners. Next slide, please. This is an example of a tool developed by the WHO to assess the health impact assessment tool. And we can use this tool, modify it, or adding some adjustment to it to assess any pharmaceutical services and pharmacy workforce. Next slide, please. So assessing the impact of the services is not enough. We need to look at the pharmaceutical workforce. We need to look at and address issues related to pharmaceutical workforce density in terms of shortage, distribution, in terms of geography and service. Education, we need to look at competency. We need to encourage and seek competency-based education. And we need to have education programs that are context-specific. Training, we need to encourage pharmacists to seek continued professional development and continued professional education. Again, we need to look at the services provided. So we need to consider aspects or issues related to specialization and role expansion of pharmacists. Lastly, accessibility. We need to look at the accessibility of pharmaceutical services, physical accessibility, and social accessibility. So impact should be assessed in isolation, should not be assessed in isolation. We need to address and understand the whole process, perhaps developing a logical framework. In the logical framework, we need to look at the input, output, outcomes, and impact, taking into consideration societal and context factors and policies and guidelines. That's it for me, and thank you all.
Thank you so much, Sajja, for that excellent presentation and taking us through impact assessment. And I believe what you showed us at the end is a logic model, which is a very useful approach for people to learn about when they're trying to assess the impact of either the services they're providing or the workforce they're providing. And there's plenty in the literature about that and how you can approach it. And from the impact and outcomes point of view, obviously we have our development goals at FIP, which you can then work backwards from. So thanks again. We may have a little bit of time for a panel discussion, and just if you've had any questions, which you've been placing in the chat box. I think some people have asked if presenters and panelists could provide sources and links in English on countries, pharmaceutical systems and services, in addition to the FIP Global Pharmaceutical Observatory, as well as laws on medicines and pharmacy regulation. I would say there's quite a lot to look at on the FIP website as well. So if you go into the publications part of the FIP website, you'll find a lot there on systems and services and the evidence behind them. And a lot of those are based on data collection and intelligence that we've been collating via the Global Pharmaceutical Observatory and other areas. So I think we've had some answers to questions in the chat. I think what I would perhaps just ask one question to each of the panelists is, one of the themes that has emerged today is the need for data, and very much if we're going to advocate for the profession or help with decision making in the healthcare. So what would be your one tip to persuade those healthcare professionals that are still resistant to collecting data as to why they should do it? So shall I start with Anne Chu? I've put the speakers on the spot a bit here because they haven't been given this pre-prepared So I'll give them a little bit of time to think if they need it.
Yeah, thanks. So this is a very interesting question, because most of the time my issue is the complaint of they have to collect too many data, and what is it for? So it's the other way around. And most of the time I'm trying to work is to reduce this burden of data collection, especially if you look at the primary healthcare level, where you have some place only 2 person. So by providing 18 different program services, and then, you know, the amount of books and checks and things that they have to do is it really take more than half of the time. So it is the other way around. Is so my question most of the time when I go to the facility is, what sort of data do you need? And, you know, the facility, if you talk to the service providers, they will say, we would like to know who are like where these people coming from and why they come so late. That is very common, especially in a low income setting countries. I think it's also, there is a very big difference between the low income countries and those who are in advanced stages, where the registries are available, where, you know, they can follow up the patient. So most of the service provider, that's what they want. They want to follow the patients up. They want to make sure that the patients get the right services and at the right time. And if they have to refer, they can follow them up and later on. Then for the facility, it is about whether we have enough drugs today, if the vaccine are kept in the right temperature, how are we going to transport those vaccines to the places where the service is provided today. A lot of that also linked to the connection between the lab, you know, where different facility, they might not be able to do the lab test themselves. So all of that is going back is what is really needed for you. And then from there, we can build a consortium of all consolidation of all different data, that then the analysis, and that is where the technology comes in to help, is with the same data, how we're going to cook them up and provide different meals to different audience, that they will be able to use it without having to collect again the same data, because they can't get access to that. So key thing, the data needs, then how we share the data and make sure that the data is open. And at the same time, the patient data have to be secured. So there is always that's the biggest question that government asks, is how can we make sure that, you know, we don't, the patient feels safe, you know, revealing the data. And the idea is that the data should be kept, for the individual data should be kept at the facility for a very few people to use it. But the aggregated data, that is where it should be shared across all different users at different level and different organizations. And we should speak the same voice to the government for that purpose. So that is my first reaction to your questions.
Thanks so much, Anshu. I'll move on to Astrid. What's your take on the data, whether it's too much or persuading people that we need it?
I think it's too much, but we don't use it. And this is exactly the problem. And when you ask the healthcare professionals to collect data, they don't see that they're actually collecting a lot of data already. But if they have to use patient data, even if it's anonymized or if it's for projects, what's very important for them is, where is the data stored? They don't like it to be stored in another country, at least in Switzerland. It is a really a big plus if you can say it's stored in our country, in Switzerland. And I mean, I don't know if the Swiss are particularly very picky about this, but we don't have any. That's why I said that we don't have a registry. We don't have this. We have a problem where, especially what Anshu said, is that we don't, the doctor or the healthcare professionals, they don't know since why do the patients come so late? Like, for example, with a diabetic foot, we always hear the doctors say, oh yeah, but they should have come 3 months ago, or now I can only amputate. And then amputation costs a lot of money. And if we could look at, and that's why we are doing this project now with the diabetic foot, that to start in primary care, that they react early enough so they can refer on time. But for this, we need to have some data. We have no idea. The data is there, but it's not structured. And that's, I think this is the most important thing, what we have to like transfer to the healthcare professionals. You have the data, let's structure it and aggregate it. Yes.
Thanks, Astrid. And I'll move on to Sajja,
Okay, thank you.
who works with workforce data quite a lot and is our lead pharmacy intelligence.
So I think we need to explain to healthcare professionals the importance of the data collection and how collected data can be used to inform the policies, guidelines, and therapeutic guidelines. Funnily enough, because if you're talking about developing countries, actually we are not collecting enough data. And we are always struggling with the lack of data and the lack of information, lack of national registries, unlike developed countries. So we need to first highlight the importance of collecting data, start training undergraduate students during their academic program, and highlight the importance of data collection, and make some sort of, or issue some sort of legislation, laws, make it mandatory, or even link it with some sort of compensation or any reward system. So that's how I think of it.
Okay.
And definitely have issues related to infrastructure, have the suitable infrastructure to support data collection and information collection.
Thank you, Sajja. Yes, that there is variability across the globe, I understand, as to infrastructure and what data is available and what isn't. So thanks everyone for your answer to that question and for your fantastic presentations. I'm just going to wrap up now as we've come to the end of this event. It's been a very informative look at how we build capabilities with pharmacy intelligence, with healthcare information systems. And I've certainly learned that we need to take a structured approach and be talking more of a common language with how we collect data, how we analyze it, how we look at the impacts, how we assess the impacts, and how we use it to make decision making. So thanks again to our presenters. A lot of the data we collate, as I've mentioned, is collated by the Global Pharmaceutical Observatory. This is the website. We have some visualizations on that website as to the data, some of the data we've been collating over the last few years, and particularly about the pharmaceutical workforce and pharmacy services. So please do visit that website if you get a chance. Just a reminder that the 80th FIP World Congress of Pharmacy and Pharmaceutical Sciences takes place in Seville in Spain, the beautiful city of Seville, on the 18th to the 22nd of September 2022, and the theme is Pharmacy United in the Recovery of Healthcare. If you want to check out all future FIP digital events, please visit events.fip.org. And just finally, thank you all so much for attending. And if you want to visit any specifics of today's event, this recording will be available on the FIP website. So take care and enjoy the rest of your day.
Thank you.
Thanks, everyone.
Thank you all.